Hello, I'm Dr. Milica Vukićević and this is Heart Failure Minutes. Today I'm delighted to be joined by Prof Akshay Desai, Medical Director of Cardiomyopathy at the Heart Failure Program for the Advanced Heart Disease section at Mass General Brigham. A leading voice in heart failure, cardiomyopathy and population-based strategies to improve outcomes for our patients. Today we will tackle one of the central tensions in contemporary heart failure care. Why evidence has advanced so dramatically, yet real-world delivery still lags behind. We will also discuss practical strategies for implementation across community settings worldwide, and finally look ahead to the future role of artificial intelligence and electrocardiography in identifying heart failure risk before clinical disease fully declares itself. Professor Desai, we have a paradox in heart failure. Clinical trials show steadily improving survival and strong benefits from modern guideline-directed medical therapy, yet uptake of GDMT in general population remains strikingly suboptimal. Why does this paradox persist?
Well, I think it's an important question because the therapies are only as good as the ones we deploy in clinical practice. And one of the challenges is that when we run a clinical trial, it is generally under carefully selected sites under the supervision of expert physicians with structured follow-up visits and longitudinal monitoring with a lot of support, and patients who have volunteered for participation and are therefore pre-selected to be more adherent to the therapy, to be more consistent with the patterns of treatment recommendations that are made. When we try to expand those options to clinical practice, a lot of that infrastructure that supports the success of drugs in clinical trials is not available. Patients are often older, they have more comorbidity, are more vulnerable to adverse effects, and I think a lot of also what happens is that we sort of deal with the day-to-day reality of clinical care, which is that patients don't always make their follow-up visits, they don't always do the laboratory testing that we request, and they don't always stay on the therapy with the same fidelity that they might in the trial. And so replicating the effects of clinical trials in clinical practice is one challenge. But the other is simply the process of getting drugs to patients. So if we think about drugs or devices that are in trials, we are generally providing all of those things at no cost to patients as part of the participation. But in practice, patients have to reach out and access not only care providers who can provide the medicines, they have to access care providers with the knowledge and the understanding of when to deploy those new medicines in practice. And then they have to be able to afford them. So in the US in particular, this has been a challenge where the cost of care is extremely high. And many patients who would be eligible for therapy simply can't afford to implement the therapies that are available. So we have to do a much better job about translating the efficacy we see in trials into clinical practice by creating structures that allow that to happen.
What are the most practical strategies to improve implementation, and how would these be applied reasonably in community settings around the world rather than only in elite specialty centers?
Yeah, that's a really useful question, and I think one of the things is that we have to create some simplification and provide frameworks that are generalizable to different clinical practice settings. And a lot of this, I think, has to be algorithm driven so that it is not really the province only of specialized experts who can make a nuanced decision. A lot of medical therapy titration is driven by measurable parameters: blood pressure, heart rate, kidney function, potassium levels, and those are routinely available in most of our practices. And if we can then develop algorithms that are guided by those parameters and scripted so that even a non-licensed provider, a nurse, a pharmacist, even a patient navigator, can walk a patient through a protocol-driven strategy, I think that's likely to be much more effective. And we have some early evidence of that from a number of different applications. Some are clinic-based applications where a nurse or a pharmacist walks a patient through a stepped therapy plan with frequent visits, some by telephone, some are virtual, some are in person, to achieve a pre-specified goal under the remote supervision of a physician, and some are entirely remote. We did one of those here at Mass General Brigham, where a patient navigator who is not a clinician approached patients for consent to participate with the supervision of their treating clinician, and we walk them through a step therapy plan over a 3-month interval where we got patients from essentially no therapy to optimal medical therapy without a clinician ever seeing the patient during that 3-month time. So we know this can be done with the right infrastructure in place, and some of it has to be taken out of the hands of the clinician. We also have to move out of these reactive models where we're seeing patients once in 3 months, once in 6 months, to ones in which we have longitudinal engagement with more touch points to make more adjustments. And all that has to be done in a framework that really safeguards patient safety. But I think it can be done, and it can be done in a way that has value to systems and can be done at low cost.
One special question for you, Professor Desai. Looking ahead, what is the role of AI using the ECG in population level detection of heart failure risk, and could preemptive therapy become the future of the field?
Well, I think the role of AI is expanding in every domain of cardiology, and we're certainly seeing that in the simple ECG, which we all get in clinical practice and is low cost, ubiquitously available across the world, we utilize very little except to identify rhythm and some features of structural heart disease. And what we have learned by application of artificial intelligence algorithms is that there's a lot more information in the raw electrocardiographic waveform than is seen on a general analysis of the ECG by a human eye. And I think what we can really pick up are signatures of subclinical structural heart disease, evidence beyond just the left ventricular hypertrophy we might see by voltage, but evidence of subtle findings of cardiomyopathy, subtle findings of ventricular dysfunction, either systolic or diastolic, some findings of amyloidosis, hypertrophic cardiomyopathy. And what this opens is the opportunity that with a snapshot in time of a patient at one point, we can anticipate the likelihood for various types of subclinical heart disease that might direct us down different strategies for longitudinal surveillance, different strategies for early intervention to prevent the development of disease, and essentially the opportunity to reorient how we stratify risk, which is largely based on clinical factors right now, but we could do with the ECG more finely to identify patients at high risk much earlier in their disease trajectory. And that opens, I think, what you very rightly call out, the opportunity for very earlier deployment or primordial prevention, where patients at risk are identified earlier in their trajectory, risk factors and early risk are recognized and intervened well before clinical symptoms develop. And that opens the possibility that we could prevent heart failure and associated conditions well before they become symptomatic. And that's a much better strategy, isn't it? Because we're in an era where reactive therapy has largely left us with still a high burden of disease and residual risk. So much better to prevent the problem before it happens.
And it will not just allow us to prevent, but also to have a good follow-up of the patients, right?
Absolutely. I think you would target some patients for treatment, but in some cases we would identify risk that isn't actionable. But we would know that those patients need to be monitored until they do develop symptoms or a clinical trajectory that merits intervention. And so I think risk stratifying on a population scale, who needs an intervention, who needs to be monitored more carefully, that's a powerful way of redirecting our resources in a way that makes sense and a way to reduce the global burden of disease in the population.
Professor Desai, thank you very much for being here today with us in Heart Failure Minutes and for those thoughtful insights. This discussion reminds us that the future of heart failure care will depend not only on discovering effective therapies, but on delivering them better, earlier, and more equitably. From implementation science to community-based care models and AI-enabled prevention, the field is clearly moving toward a broader population health vision. I'm Dr. Milica Vukićević, this is Heart Failure Minutes, and I'm signing off for now. Until next time.